How do we use cerebral oximetry in clinical practice? So we know what are normal cerebral oxygen saturation values. We now need to know what are critical or threshold values associated with brain injury. The best data in pediatrics comes from neonatal piglet survival models, in which the piglet is rendered hypoxic and or ischemic, and following this is examined neurologically, and after sacrifice the brain is examined histologically. Dean Kurth did a study looking at levels of functional impairment associated with cerebral oxygen saturation. Cerebral oxygen saturation data is within the red circle in this table, and the values shown are medians with 95% confidence intervals. What you see is when cerebral oxygen saturation falls to the mid or low 40s, you start seeing an increase in brain lactate and a decrease in power of the EEG. With cerebral oxygen saturation values in the 30s, you start seeing further decreases in EEG amplitude, as well as slowing of the EEG and a decrease in cerebral ATP. As you notice, the 95% confidence intervals are very wide, and this represents the biologic variability which is present both in neonatal piglets and in humans. So one knows at what cerebral oxygen saturation value we start to see cerebral changes, but how long should the saturation be at that value before you get irreversible cell injury? Dean Kurth did a follow-up study where the cerebral oxygen saturation was held at 35%, and only after 2 hours were they able to detect neurologic abnormalities in the piglets and histologic damage. Another group of investigators made piglets hypoxic for 30 minutes. With cerebral oxygen saturation values in the 30 to 40 range, although the EEG was normal, they started to see functional zone injury in the mitochondria. And with saturation values below 30 for 30 minutes, they started to see a decrease in EEG amplitude and significant injury in the hippocampus. So we don't know the exact viability time threshold, but it's likely to be somewhere between 30 minutes and 2 hours. It's also important to note that in humans, neurodevelopmental testing is very sophisticated and may pick up injury much sooner than the 2 hours seen in piglets. So how does one use cerebral oximetry in clinical practice? I think the best way to think about it is in terms of ranges and direction of change. So if 60 to 80% is the normal range, above this value, there's either cerebral hyperemia or a change in cerebral oxygen consumption so that supply exceeds demand. Dean Kurth has referred to values between 45 and 60 as a buffer in which the EEG is normal and brain lactate and brain ATP are also normal. In the 40 to 45% range, you see a disturbance in that the EEG amplitude begins to decrease and cerebral lactate increases, but the ATP level is still normal. In the 30 to 40 range, you start to see energy failure in that the EEG becomes flat, brain lactate is further increased, and brain ATP is decreased. And below 30%, you have the potential for cell damage. So the range of 30 to 45% is considered the viability threshold, as I mentioned earlier.